So I just want to start by saying thank you to all of you for being flexible in how you've joined us today. We have enjoyed hosting hybrid seminars and having folks come in person. Respiratory virus season is posing some challenges or some opportunities for flexibility for us. So want to say thanks to everyone for being willing to join virtually today. I think sometimes, we had a couple years of exclusive virtual conferences. Sometimes they're less conversational than I wish they were. So I will preface this by saying we've done the first three of these talks in tandem, and today it's just me. So I think please, anyone jump in at any time. I am notoriously bad at manning the chat. So I'm going to have Santana, who's our assistant director, man the chat for me. But even better than typing something into the chat is perhaps just coming off of mute and sharing either your thought or your question with the group. I think we all have a lot to learn from one another. Yeah, I'm trying to think if there's anything else I wanted to share. Also, I think one thing that I really enjoy about doing implementation science research is the collaborative nature. And so with that in mind, hopefully we can all sort of like collaboratively learn together and people can share what they're thinking with the group or any questions that arise. So with that, it's nice to see some familiar names and faces in the Zoom room today. I am Catherine Fantasia. I am faculty with the Evans Center for Implementation and Improvement Sciences. Just in case there are any new folks in the room, I wanted to introduce the Evans Center for Implementation and Improvement Sciences again, just to tell you who we are. So we are a methodological hub for implementation science and safety net settings. We provide guidance, support, and innovation in research design, and we also enjoy educating the BU and BMC community on implementation and improvement sciences, and that's part of what we're aiming to do with this seminar series. There are a couple of different ways to engage with CIIS. So the first is the monthly educational seminars. You found your way here. That's them. But we also offer research consultations that are free of charge. I just want to put that out there. We don't charge any money for our services. You can request a research consultation with members of the CIIS team by going to our website, which is located here at cites.bu.edu/CIIS. There's also a lot of information on projects that we've worked on. Some helpful resources. I will say we are in the midst of a website revamp to make it even better and more helpful. And all of these seminars are being recorded. And so if this is your first time joining us, or say you've joined once before, but you've missed some seminars, our others have been recorded and they are available online. Right now, in order to get access to the recordings, we just ask that you email us, but we are in process on migrating recordings to a web platform for lower barrier viewing. All right. So for those of you who have joined us before, you've heard us introduce the team, but we are a multidisciplinary team. Again, one of the things I really enjoy about implementation science. So our director is Mary Lynn Drainoni, who is an implementation scientist and a qualitative methods expert. She's waving. Hey, Mary Lynn. Our associate co-directors are Kirsten Ostad and Nick Bosch from Family Medicine and Pulmonary, and they bring qualitative and quantitative expertise respectively. Santana is our assistant director. She has a public health background. Kayla, who hopefully is resting, is an applied medical anthropologist and brings qualitative methods expertise. Shayna is an epidemiologist by training and sits in the section of infectious disease. Gabby is a neonatologist, is now CIIS faculty, was a CIIS fellow with me. I'm Catherine, I'm an endocrinologist. And then our two current first-year fellows are May Alansari, who sits in developmental pediatrics. She's a pediatrician, and Katie Rizzolo, who's out on maternity leave, who is a nephrologist. And so that's our team. We represent a diverse area of interests and backgrounds, and that's something I enjoy about implementation science. All right. So, like I said, this is the fourth in our 8-part series, which is designed to cover key aspects of implementation science and provide an overview of implementation research. Today, we'll be talking about implementation strategies. In the sessions coming up, which will be in the new year, we'll be covering outcomes and measures, quantitative, qualitative, and mixed methods, and fidelity and adaptation to round the sessions out in the spring. And today, I hope that by the end of this talk, everyone will be able to define an implementation strategy, to describe the differences between interventions or evidence-based practices and implementation strategies, to understand the ways in which you can select implementation strategies, and to review how to describe, operationalize, and measure strategies. Okay. So what exactly is an implementation strategy? So implementation strategies are the approaches or techniques that are used to enhance the adoption, the implementation, sustainment, and scale up or spread of an innovation. So in 2009, the NIH defined implementation as the use of strategies to adopt and integrate evidence-based practices and to change practice patterns within specific systems. Implementation science was already an emerging field by that point. Now it's several decades old, but it arose to understand the factors that facilitate or impede implementation, to develop effective strategies for implementing evidence-based practices and processes, and to improve health-related processes and outcomes. It also seeks to produce generalizable knowledge regarding these strategies by understanding the processes, the barriers, and the facilitators that influence adoption and influence implementation success and failure. And what it seeks to do is develop, test, and refine relevant theories as well, to advance the science of implementation. So implementation strategies, they can be used discretely or individually, or through multifaceted approaches, which in some cases are required. And they can target a range of recipients and multi-level contextual factors, which can range across the levels of the social ecological model, from the individual level up through public policy. So because implementation science is primarily concerned with identifying effective strategies for implementing evidence-based interventions, it's pretty critical to understand the difference in what is meant by an implementation strategy versus evidence-based intervention. So evidence-based or evidence-informed practices are the programs, the policies, the procedures, the products, the pharmaceuticals that are effective at improving health behaviors, outcomes, and environments. They are the thing or what you want people to do or to use. Implementation strategies are the active ingredient in the process of moving evidence-based or evidence-informed interventions into the practice of usual care. So these, again, are the actions taken to enhance adoption, implementation, and sustainability. They are how you will get people to do the thing. So an example of this is hand washing. So hand washing might be the evidence-based practice you want people to do to decrease hospital-acquired infections. So changing the location of, say, like alcohol-based hand sanitizer and hand washing sinks to just outside of patient rooms in the hospital may be the strategy you get people to use to clean their hands. All right. So because identifying, developing, and testing implementation strategies are important goals of implementation science, it is important for us all to speak a common language because inconsistent language and inadequate descriptions of implementation strategies in the literature have hampered efforts to sort of like accrue this evidence. So in 2015, the expert recommendations for implementing change, the ERIC study, was published, and it aimed to define or to refine a compilation of implementation strategy terms and definitions to allow for replication efforts and further analytic evaluation across the literature. So using a multi-stage modified Delphi approach, they produced a taxonomy of 73 discrete implementation strategies and definitions. These implementation strategies, like I said, can be used discretely, so individually, or, as I mentioned earlier, can be combined into multifaceted or multi-pronged strategies. And subsequent to this, they sort of examined the relationships between strategies, their relative importance, and their feasibility, according to expert consensus, and developed 9 conceptually distinct groups, as is seen here in the bottom. I think that should be the bottom left of your screens as well. I don't think it mirrors. So these span from engaging consumers to training stakeholders to changing infrastructure and using financial strategies. And we'll talk about some implementation strategies today that sort of span a variety of these conceptual areas. So some examples of implementation strategies and their clusters are seen here. And as I mentioned, we'll talk through some of these, and some of them are highlighted in our case studies. But these, for example, if you're using an evaluative or an iterative strategy, you may be using audit and feedback. If you are seeking to develop stakeholder interrelationships, you may be identifying and preparing champions as an example of that. To train and educate stakeholders, you may be developing educational materials. To provide interactive assistance, you may be using facilitation as your strategy. And to support clinicians, you may be reminding them. And there are a variety of ways you can remind clinicians. I'm sure you can think of many, but best practice advisories or order sets are just some examples in the electronic medical record of ways that we can remind clinicians. So facilitated by the consistency in terminology that's been developed, the evidence base for implementation strategies has been accruing, and evidence syntheses for both discrete and multifaceted implementation strategies has been growing, as shown here. I've just pulled, a very small number of systematic reviews on individual or discrete implementation strategies. And the Cochrane Collaboration's Effective Practice and Organization of Care group, the EPIC group, has over 130 systematic reviews of strategies such as audit and feedback, which was published some years ago. I think that one was published in 2012. They have a systematic review on opinion leaders. Here, this one on printed educational materials was updated in 2020, and they have them on educational meetings, just to name a few. So now that we've reviewed what implementation strategies are, I want to move forwards into discussing how to select them. And you can operationalize implementation strategies from theory or frameworks, from contextual realities that you identify through formative evaluation, and these are pretty important. So for example, the strategies you use in like a low resource acute care setting might be very different from what you would use potentially in like a very well-resourced primary care clinic. And formative evaluation can also be a way to understand what's going on in a particular context and what's acceptable to help decide on strategies to use. There's also empirical evidence for strategies, and there's stakeholder preferences. And identifying stakeholder preferences for implementation strategies can be done in a variety of ways, including some interesting methods that I recently learned about at the D&I conference. So a group of us just came back from the 16th annual conference on dissemination and implementation science. I learned about interesting methods such as innovation tournaments and clinician crowdsourcing challenges as ways to elucidate stakeholder preferences when it comes to deciding on implementation strategies. A systematic review ultimately has concluded that tailoring strategies to help address determinants or barriers and facilitators was more effective than no strategy or a strategy that's not tailored to determinants. But ultimately, no specific method for selecting strategies has, as of yet, been proven superior. And so all of these ways that you can operationalize a strategy are reasonable methods. Ultimately, at the end of the day, the most important thing is that the strategy you choose must be justified. So the thing you want to avoid is the, it seemed like a good idea at the time approach when it comes to strategy selection. So it's important to ensure that your strategies are justified and that there's alignment between your strategies and your framework constructs. So ask yourself, do these things make sense together? As an example, if you plan to use an educational strategy, for example, training, do you have evidence that knowledge or lack of knowledge is a negative determinant? And does your framework suggest that knowledge or awareness is an important part of achieving implementation? Similarly, another example is if you're using PARIS or IPARIS, facilitation is proposed as a specific strategy that's an integrated component of that framework. It's already baked in. And so are you using facilitation and what does that look like in your study? One framework that can be used to help identify strategies that target particularly relevant functions is the behavior change wheel. So this is a synthesis of 19 behavior change frameworks. And at the center of the framework is the COM-B, or the Capability, Opportunity, Motivation, Behavior system. And over that, you can map the theoretical domains framework. And this central framework allows us to identify the conditions that are necessary for behavior to take place, and then to map those to one or more of 9 strategy functions that are aimed at addressing deficits or negative determinants in one or more of these conditions. And then it can be further mapped to 7 policy categories that help to support strategies. And the behavior change wheel was developed by Susan Mickey and her colleagues, and they also have a behavior change taxonomy that helps you to understand like what strategies based on these functions may address some of your negative determinants. Another framework-based tool is the CIIS matching tool. So in our theories, models, and framework discussion, we talked about CIIS, which is a determinants framework. And I'm sorry, I was getting a phone call. This tool was developed based on expert consensus. So they convened a wide community of almost 170 implementation researchers and asked them to specify the top 7 ERIC strategies to address specific CIIS-based barriers. These results were then used to build an online tool that can help you to select implementation strategies. And you can access this tool at the CIIS website under their strategy design tab, or this is the URL you can travel to. And then you want to click on this button, Implementation Strategy Selection Tool, and it will download for you an Excel document where you can indicate if you've used CIIS to do some formative work and use CIIS, prospectively to identify, what potential negative determinants are, which implementation strategies may address those CIIS-based barriers. In the paper that talks about the development of this tool, which was written by Waltz and his colleagues, they do advise to use this tool with caution, and that's because it has yet to be rigorously prospectively studied. But I read recently an interesting article by Sherry Rogel that looked at a group of implementation researchers in the VA system and asked them strategies that they use to improve care for patients with cirrhosis, and which implementation strategies were used and at what stage of projects. And then they retrospectively looked at if the strategies used would have mapped to determinants that were identified through CIIS. And what they found was that the majority of sort of like the top strategies that had been found to be effective actually would have been recommended by the CIIS ERIC matching tool. And here is another way to sort of like think about this. So if you've done formative work, you can think of matching strategies to determinants you've identified. And here's some examples of that. So if you found out that people are interested in doing something, but they just don't know how to do it, so lack of knowledge is your negative determinant, or a negative determinant, perhaps your strategy is like interactive education sessions. If what you're hearing is that what people perceive as happening isn't actually consistent with the reality of what's happening. So for example, people think that they're doing a great job of screening for hepatitis C and that their hepatitis C screening rates are really high, but the data actually shows otherwise, then audit and feedback can be helpful to bring awareness to actual practice patterns. For example, if people have beliefs and attitudes that serve as negative determinants, using peer opinion leaders can help to modify beliefs. And if a system is not well set up to support a process, for example, we'll talk in our last case study about the distribution of nasal naloxone from the emergency department. The process was just not well set up to distribute nasal naloxone in the beginning. You may want to engage in a process redesign.
Yeah,
So
can I jump? You said we could jump in.
I would love for you to jump in.
No, because I feel like for me, as I listen to you and listen to this whole thing, I think about obviously what we're studying in CIIS is like that level down, right? Where we're looking at strategies. And to me, one of the things that sometimes I feel like I struggle with here and working with people who are on the ground doing like really important work, they just want to pick a strategy because they think it'll work, right? And that's one of the big differences, I think, in some ways with QI versus CIIS, right? Is it's what is it grounded in?
Right. And so I think going back to this slide, as long as you're grounded in I think some of these, you're on the right track. You're not just assuming like, oh, this seems like a good idea, let's try it.
Right.
Is that what you're getting at, Mary Lynn?
Yeah, I am. I'm getting at that. I feel like that is where we get a little bit stuck. And I think the other place we get stuck is that we're thinking about comparing interventions and not comparing strategies, but that's a much bigger issue.
Yes, and I hopefully will, through the case studies, clarify what we're, that sort of difference between intervention and strategy, and really hone it in. That like the strategies are the how we get people to change behavior, because ultimately when we do implementation research, there is behavior change that occurs. And so how do we change behavior?
Thanks.
So I think I was just going to add, if that's okay, Catherine, is just to say that, there's definitely been a lot of commentaries about how we tend to pick, or researchers tend to pick easy implementation strategies that tend to be at the individual level, as opposed to doing what Catherine is recommending, which is matching them to determinants, which often means working higher up at an admin level and changing systems. And so, again, I think that just sort of relying on this importance of matching the determinant to the implementation strategy, because the attractive thing to do is just pick the easy option.
Thanks, Kirsten. And I will also point out that in the Waltz concept mapping paper, the other thing that the implementation researchers were asked to do was to like rate relevance and feasibility of implementation strategies. And so if you're asking yourself like, how relevant might this implementation strategy be and how feasible is it, you can actually look at that Waltz concept mapping paper where, a large group of implementation researchers has, based on their expert opinion, given you some ideas or some thoughts about feasibility. All right. So one thing that's really important, and I alluded to this when I was talking a bit about the reason for the ERIC project and that development of that taxonomy of implementation strategies, was consistency in language. So consistency in language and specificity is really important, and it's so important because it helps us to build a strong evidence base for implementation strategies. And in order to build the strong evidence base, it requires that, the use of strategies be tracked and reported in enough detail to understand what strategies exactly were used and whether or not they were effective, and for also other researchers to then go and replicate the use of these strategies for us to be able to synthesize findings across studies. So Anola Proctor wrote an article on how to specify implementation strategies. It was published, thanks, Santana. It was published actually prior to the publication of the ERIC project and those 73 implementation strategies. But in it, she outlines how to identify a strategy. So use consistent language. I would urge us all to use consistent language, that matches at least for now, the taxonomy put forth by the ERIC project, to operationally define and identify the discrete components of your implementation strategy, because we know that the 73 discrete implementation strategies that are in that taxonomy produced by the ERIC project can be thought of as like building blocks to create multi-pronged implementation strategies. And then she goes on to say, you must specify it. And in order to specify it, there are 7 domains that should be articulated with respect to the implementation strategy. So the actor, so who is enacting the strategy? Is it an individual? Is it, a health system? What is the action exactly that is occurring? Who is the target, or what is the target of the action? Who is the recipient? When or at what phase is an implementation strategy being used? At what frequency and intensity is an implementation strategy being used? So for example, you decide that you are going to, provide educational outreach as your implementation strategy. Does that mean you're doing 1 session, or does that mean you're doing monthly sessions for 8 months? Big difference. And then what implementation outcomes do you think will be affected? You should measure those. And what ultimately is the justification for why those implementation strategies, or why that implementation strategy was chosen? And like, we said earlier, it can be empirical, it can be theoretical, or it can simply be pragmatic. Okay. So moving forwards into the case studies that explore the practical application of implementation strategies, we are using the same cases that we've been using throughout this seminar series. I think that this model allows us to sort of like dive a little bit deeper with each session that we do. But we'll start with the hepatitis C assessment and testing project, the HepCat project. So this was a study that was published in 2012. Mary Lynn was one of the investigators. And this, just as like a brief reminder of the study and the project that was done. So in this project, the problem or the gap was that there were a significant proportion of people with hepatitis C who were unaware of their diagnosis because screening rates were really quite low. And what was done was 2 different methods of screening for hepatitis C. The evidence-based intervention, or the evidence-based practice, was a risk-based questionnaire for screening and a birth cohort screening. So like everyone born between certain years was screened. 2 different methods for screening were implemented at a group of primary care practices affiliated with the Montefiore system. And the framework that was used for this study was the Proctor conceptual model of implementation research. And the strategies, and here I've characterized this and categorized the implementation strategies that were used in this study according to the ERIC strategies. And I will say that this study was done prior to the publication of the ERIC project. So Mary Lynn, please jump in because you actually were one of the investigators. So if you think that anything, if I've missed anything or anything is miscategorized, but I've sort of applied the ERIC implementation strategies to the implementation strategies that were used in this project. They were first to remind clinicians. So that was done through a variety of mechanisms, but there were environmental reminders. So there were buttons like swag that people received. There were pocket cards. There were posters in the clinics. And then there were also stickers in the paper charts that indicated when an individual was eligible for screening. There were educational sessions, and those occurred both prior to the study and during the study. There were champions within the clinic who helped to encourage this behavior. And facilitation was also one of the strategies. And what that looked like was that the study staff would visit the clinic twice a week to encourage adherence to screening practices and to elicit feedback on the project.
You got it right.
Cool. Thanks, Mary Lynn. And Proctor's conceptual model of implementation research was used here, and it can be a helpful framework for thinking about implementation strategies at multiple levels. I mentioned the social ecological model earlier on, just to say like that implementation strategies, and Kirsten mentioned this as well, can occur at multiple levels, from the individual level up to the policy level. But where you may want to intervene can depend on whose behavior you want to change, or where the literature tells you to intervene. So you might want to intervene with patients or clinicians at the individual level. So oftentimes that's like knowledge-based interventions or educational interventions. You may want to intervene at a group or a supervision level, or at a larger level, like at a unit level, say in the emergency room or the ICU. We'll talk about those, or larger organizational levels, such as across a hospital, or larger systems levels, like across a health system. And so thinking about the implementation strategies that were selective, there was formative work that was done to understand determinants of screening at the location the study was conducted. But also there was information that was drawn broadly from the literature on why there were gaps in Hep C diagnosis rates and gaps in screening. So one thing that was identified was that a major barrier was limited knowledge about what the best strategies were for Hep C screening and testing in primary care. The awareness that Hep C testing was rarely initiated by primary care clinicians, both in the local context, but that was also demonstrated nationally, so like drawn from the literature. Additionally, it was learned that very few people were tested, even if a primary care clinician identified risk factors. And there was also a concern that patients were underreporting risk factors to primary care clinicians. And last, it was identified that many people in need of testing weren't being identified through standard screening. That was at the time the birth cohort screening. So based on that formative work, Proctor's framework was used, and this study actually used strategies at all levels. So at the individual level, there was a script that was used to standardize and normalize the high-risk screening tool. At the supervisory level, there was regular communication between the research team and clinical leadership, and facilitation that went on with the project staff visiting multiple times a week. At the group level, there were educational sessions for the primary care clinicians and the staff. At the organizational level, there was a champion who was there to support their colleagues. And at the environmental level, it sounds like there was just like lots of reminders everywhere. And this happened across primary care clinics in the health system. So the next case study is the implementation of phenobarbital, or a phenobarbital-based protocol for severe alcohol withdrawal in the medical ICU. And this was a study that Nick and Mary Lynn participated in and was published in 2021. And so this study was actually done in the medical ICUs here at BMC. And as a quick reminder on this study, the problem here was that traditional treatment for severe alcohol withdrawal syndrome with benzodiazepine therapy is associated with adverse effects, including intubation, mechanical ventilation. And phenobarbital, which was an evidence-informed intervention, was potentially comparable and had fewer adverse effects. And so the intervention here is an evidence-informed intervention. It was phenobarbital-based treatment for severe alcohol withdrawal syndrome in the ICU. And the framework that was used here, again, was the Proctor conceptual model of implementation research. And we do just want to stress that even though the same framework was used in two of our case study examples, it doesn't mean that you should or need to use Proctor for your implementation research. It was used in these cases because it just fit well. And so I think thinking about fit and, what your sort of like goal for your implementation research is, what are the potential determinants, and does that align with your framework, and what are you seeking to accomplish, what are your outcomes is important. So the implementation strategies that were used here were reminding clinicians. So there were environmental reminders, there were like laminated phenobarbital protocols that were posted in every patient room in the intensive care units. And there was an EMR order set that was created to remind clinicians of, you know, how to order the phenobarbital and what to order exactly. And then there was also training that was done for the clinicians who worked in the ICU. And so again, looking at the strategies by the level targeted with each strategy, at the systems or environmental level, there was the EMR order set or workflow, which was created to, again, remind clinicians what to order and how to order it. There was the laminated flow sheets in all of the patient rooms, which was to serve as a reference and allow for easy access, but also serve as a cue to order this. At the organizational level, this new protocol was introduced, and at the group or learning level, there was training and education that was provided. And our last case study example is nasal naloxone distribution in the emergency department here at BMC. And Marilyn participated in this study as well, along with colleagues in the emergency department. So again, a quick brief overview of what the problem was and some brief highlights of the study. So the problem here was that only 8% of people who were coming into the emergency department with an opiate overdose or at high risk for overdose were receiving a prescription for nasal naloxone as a harm reduction measure. The evidence-based practice here was the prescription of nasal naloxone upon leaving the emergency department as a harm reduction measure. And the framework that was used here was the promoting action on research, implementation, and health services. The implementation strategies were education and training. So there was like email communication that went out. There were posters. Physicians were talking to each other about this, this new policy to deliver nasal naloxone to folks at risk or who had come in with an overdose prior to departure from the emergency room. There was a de facto clinician champion. So someone had been sort of had like arisen as a clinician champion, but it wasn't sort of like a clearly designated role. There was a revision of professional roles. So the Project Assert drug and alcohol counselors had been trained on the education, the patient-facing education and distribution of the naloxone kits. And there was also a change in service site. So in this new state, there was the ability to prescribe and receive the nasal naloxone to, give to the patient before they left the department from the ED and inpatient pharmacies. So that was something that had not previously been available and was made available. Early on, it was identified that unfortunately, these strategies just weren't very successful. In fact, there was actually no change in the proportion of people who were, potentially eligible who were leaving the emergency department with a prescription for nasal naloxone. And so it was really important to understand why that was and necessary to rethink the implementation strategies that were being applied. So to better understand why the rates of distribution were low, qualitative work was done, and it was examined through the CIIS framework or using the CIIS framework. So thinking about the evidence, clinicians in the emergency room believed in the effectiveness of Narcan. They didn't have doubt that Narcan worked, but they had limited experience distributing Narcan at discharge, and they believed that patients were not receptive to receiving Narcan at discharge. And that experience and their beliefs about patient receptivity fall into the evidence construct in CIIS. And so that was low. The context was like relatively strong. So there was leadership that supported the initiative. There were multiple resources that were dedicated to it. In addition to training the Project Assert drug and alcohol counselors, they also expanded ED social work presence. And so there was more social work assistance in the evenings. But there wasn't consensus about what the role of the emergency department should be and is with respect to this public health initiative. So this was sort of like part of a broader state of Massachusetts public health initiative, is my understanding. But where things really fell apart was in facilitation. So the training that people received about how to actually go about getting Narcan in hand to give to their patients was episodic. It wasn't consistent, and there weren't partnerships that had been developed with respect to the development of the policy or the training that was occurring. And here those themes have been organized according to the positive and negative determinants, or the facilitators and barriers. So the facilitators for the project, or for this implementation, were that the intervention was driven by things that were happening in the real world. People philosophically supported this, clinicians supported it, and the leadership supported it. There was some early basic education and training, which was good. People liked that. And there were resources made available to assist. Also, they had changed sort of the availability of Narcan so that patients were able to leave the emergency department with the naloxone kit in hand. However, the things that served as negative determinants were that the protocol was unclear. It wasn't clear sort of like what at risk meant. The policy was inconsistent, and the policy was inconsistent with usual practice. So this wasn't something that they had been doing before. Furthermore, the workflow was cumbersome. So what they were doing to actually get these Narcan kits in hand was that a verbal order was given by, a physician, and then a paper order had to be generated for the pharmacy. And this was despite the fact that like Epic was being used for sort of like all the other routine care that was happening in the emergency department. So it was a very separate workflow that had been created and not consistent with usual practice. There were also the patient-related barriers that I mentioned, lack of clarity in who was responsible for this task, for who would be prescribing the naloxone kit, who would be doing the education, and then the education and training to clinicians around this initiative had been episodic. So this formative evaluation was then used to understand and to develop new strategies that were suggested by staff according to the Paris framework. So thinking about the evidence, things that came out of this formative work with staff was that offering a clear definition of patients who are at risk for overdose was really critical. The clinicians felt like they had just been guessing, which led to low rates of naloxone kit prescription. They also asked for the development of a training program for caregivers and families, because they felt that the idea that you would train patients who may not be interested in nasal naloxone and can't use the medication on themselves was a barrier to use. And then for the context, in the beginning, the ED pharmacy availability was not 24/7. And so oftentimes when, the need for the naloxone nasal kits was highest, which was overnight, folks weren't able to get it. And so increasing ED pharmacy availability was a strategy, and streamlining the Narcan distribution process to mesh with typical workflow was suggested. And that's what I was talking about with, this transition to an Epic order set as opposed to this like verbal to paper order thing that had been going on. And then really important was changing the way in which this was facilitated. So the staff suggested clear and specific identification of roles and responsibilities. So who was supposed to do what and when, and identification of an official site champion, and consistent training for all ED staff was suggested. So to summarize and to try and drive home this difference between intervention or evidence-based or evidence-informed practice and implementation strategy, I just want to summarize from our 3 case studies what those were. So in the HepCat project, in the Hep C screening in primary care clinics, the intervention was screening for hepatitis C using the birth cohort and the risk-based screener. The strategies to get people to screen were facilitation, education, and environmental reminders. In the study looking at implementation of a phenobarbital-based pathway in the ICU, the evidence-informed intervention was the phenobarbital-based alcohol withdrawal syndrome protocol. And this study was also a study that looked at the effectiveness of that. And Shana and Katie spoke about that in our last seminar. And the strategies for implementing this phenobarbital-based protocol were training to clinicians in the ICUs, reminding clinicians through the use of laminated protocols and the EMR order set. And lastly, for the nasal naloxone distribution in the emergency room, the intervention was the distribution of the Narcan kit from the emergency department prior to discharge. And the strategies that were used were training and facilitation, revision of roles, and a change in the service site for distribution of the Narcan kit. So we hope that, at the end of today's session, you'll be able to appreciate that implementation strategies are the methods of getting interventions or evidence-based practices into action. They're the how we get people to do the thing that we want them to do, or we hope that they'll do. You can operationalize strategies from frameworks, theoretical concepts, existing evidence, or stakeholder preferences. But ultimately, it's really important to think about what will best fit the goal of your study and your intervention characteristics, so your evidence-based practice characteristics. Your strategies must be justified, and they should address determinants in the setting and link back to the framework you use. And it's really important to advance this field forward, and so that people just understand what it is exactly that you've done, that you be clear about your strategy. So please name it, define it, and specify it when you operationalize it. This helps us build the evidence. And with that, we're happy to take any questions, and we hope that you'll join us next time, monthly Thursdays. I think this is the second Thursday from 1 to 2 p.m., usually in the Evans seminar room, but also by Zoom. Our next session will be in the new year. So happy New Year and happy holidays to all who celebrate winter holidays. We hope that you will take our quick evaluation of our seminar series, so you can take a picture of the QR code. And yeah.
Catherine, I have a really provocative question, because we work in a medical setting. And I feel like usually when we get a request or someone wants us to work on a project with them, right, they really want to focus on interventions. I'm back to my interventions versus strategies issue. And they really want to compare interventions or do some kind of comparative effectiveness of that versus strategies. So, and this is the challenge, right? That implementation science is really multi-level, and we really want to compare strategies as implementation. How do you get the Narcan? I see Jim Feldman here as part of the Narcan study. How to get that into people's hands, essentially, right? Was the strategy. It's not Narcan. It's not the intervention. But in many studies, particularly I find with clinicians, which is great, they want to compare interventions because we want to know what works, and we want to, and the idea of a hybrid is to rapidly move things into practice. So you study the strategy, but do you feel like it's really hard I'm
going to go to
do strategies when you're trying to study interventions as well? And then Jackie, hopefully we can answer your question in a sec, but it's sort of something I struggle with all the time. Can you really do a hybrid too? Can you really pay equal attention? And should we be more rigid about that? I don't know, just a thought, and anyone can answer. It's sort of something that's always in my brain.
Marilyn, I wonder if this is like where factorial studies might come in, where you have groups that are assigned, to intervention versus no intervention, and to, strategy 1 versus strategy 2. I don't know what your thoughts are on that, if that's maybe a way to sort of tackle those questions.
Maybe. It's not, and I'm not asking you to answer the question. I just think it's a thing that kind of rolls around in my brain almost every time I do some kind of a consultation or conversation, or even write my own grants. I don't know what other people think. I think it's just hard to give equal attention to two things, right? For all of us in the world, whether it's in research or anything, it's hard to give equal attention to two things, isn't it? Maybe not. Maybe it's just for me. So, I don't know. Maybe it's more of a theoretical question. I just don't know what to do about the focus on intervention when we're thinking about strategy. Curious.
Yeah, I don't know.
This is Karsten. I'm a clinical health services researcher in GIM, and I work with Merlin on the healing community study and the CFAR. And I can give one example. First, I wanted to introduce Dr. Mahmoud Al-Khadrou, who is a medical doctor from Damascus, Syria, who went to medical school in Russia and in Ukraine, and now is working on an implementation science study that partly addresses that challenge about being interested in the implementation and how to make it work, and identifying the right implementation strategies. And we conducted a behavioral intervention study in Russia, aiming to help people people with HIV and substance use cope with stigma. And our challenge is that we collected the data at the site of our clinical trial in St. Petersburg, Russia. And since there has been escalation of Russia's war against Ukraine, and it's no longer possible to conduct research there. So now we have this implementation data set, both quantitative and qualitative, and we are trying to identify implementation strategies to give NGOs a tool set or a guidance at hand on how to implement a stigma intervention like that at NGOs. And we have to find an approach that kind of works generically across settings, although especially stigma is very culturally is created and experienced in a culturally very diverse context. And our approach was to start with an implementation logic model, and we're now trying to find the right framework to identify the implementation strategies for that. We might actually loop that back to you.
Absolutely. Feel free.
Getting back to your kind offer for consultations.
Absolutely. I think we're the only
Thank you.
free consultation service.
Catherine, I was just going to ask, in a clinical trial, you often set what is a clinically important difference to observe. And one observation that I would make about the nasal naloxone project was there was a lot of sensitivity that anything could be seen as critical. In other words, anything, if you get in any of these projects, if hepatitis C screening increases 2%, 5%, that's better than nothing. And I wonder what you think about that.
I would welcome other people's thoughts, but yeah, I mean, I think it has to be sort like you may see statistical significance, but is that clinically meaningful? Is like a 1%. I mean, I can share an example of something we've recently done, which is not related to Narcan, which is, as Marilyn says, a death averted potentially, which is maybe, you know, slightly higher stakes, but we participated in a study looking at a bundle of strategies to try and increase fatty liver disease screening in a weight management clinic, and using transient elastography, which is ultrasound technology, to examine the liver for fibrosis in people who are at high risk for fatty liver disease. And we saw like a 1.3% increase in, you know, the rates of getting transient elastography, which like just doesn't feel like, yes, that might be, you know, I don't know if it's clinically significant because I don't know if we looked at that, but or statistically significant, but is that really clinically significant? We saw like there was a change from 0 FibroScans ordered to like 4. And to me, that didn't feel meaningful. That doesn't feel like we've meaningfully shifted or changed behavior with what we've done. I don't know if people have other thoughts about that.
This is Kirsten. I think the challenge is that we all know that our healthcare systems have limited bandwidth. We can only ask so much of clinicians, nurses, of everyone. And so there has to be some like prioritization of saying this is going to be the biggest impact, you know, strategy for this, or the, you know, combination of evidence-based intervention and strategy. So I think that's the challenge, is just making sure that what we recommend and what we put out there is actually going to meet that criteria.
I'm conscious of addressing Jacqueline's question. I don't know that I fully understand it. Maybe
yes, I think it comes directly from a slide, Catherine, you had on.
Yeah, I think, Jacqueline, if what you're asking is like, what do we mean by saying like a pragmatic justification?
Yeah,
So,
just an example.
yeah, so like if you do a needs assessment and you identify that, that maybe there are multiple negative determinants, but certain strategies may be more feasible. That to me would be a pragmatic justification for the implementation strategies you use.
Got it. Okay, thank you. That was helpful.
Because the best thing may not be a doable thing, right? I'm still struck on Jim's question, like, is one death averted? Yeah, I mean, Ed, yeah, you guys in the ED would have said, yeah. When you're talking about life or death, right?
Right. I mean, I guess if it's not been discussed in the implementation science literature, it might be something to think about.
It would
You know,
be. Why don't you write a paper? Why don't you write a paper with us? We're always looking for new methods things. We always want to do new methods things and innovate.
Got it.
I also think that highlights the importance of mixed methods, because even if there aren't quantitative, like
Yeah.
significant quantitative outcomes achieved, there might be, if you do look into qualitative outcomes, there might be some significant changes elucidated there.
That's a good point, Santana.
Mhm.
I think too, implementation science is generally like you're going to keep iterating on it, right? So you have, I wouldn't necessarily call those 4 scans like a success.
Oh, no,
But for
I
those
definitely
ones-
don't think they're
Yeah, I know. But like, it was successful in that you figured out something and you learned, and then you're going to keep trying, right?
Yeah.
Like, if it had worked 100% of the way, you still have more to do because it's one weight management clinic. So you just got
Absolutely.
slightly less far. But-
No, such a good point, Rebecca, I think that you're raising, which is that, and I think we reflect on this, a decent amount, when we talk about the projects that we do and the studies that we do. There is a lot to be learned from, failed implementation or negative results to an implementation study. And it's like, what are the methods by which we can go about, learning from those negative studies?
The other thing I reflect on a lot, and I think of my failed implementation, my recent one, very failed, but are the state, and we talk about ourselves as CIIS and what makes us different than other implementation science places. There's many things, but one of them is that we have this safety net focus. Is the bar lower because the stakes are higher? Some part of me thinks about that.
Can you say what you mean by is the bar lower?
As the Jim's question about
Yeah.
do we need statistical significance, or what level of significance, or what level, because the stakes are higher. We have a failed implementation of long-acting injectables for HIV in a street-based medicine setting. And when I was trying to present how to present the failure to all my colleagues, one of them, who's completely a quant researcher and not in this space at all, said, what you're saying essentially is lower resource patients need like higher resource settings. And so I guess what I'm saying is the bar lower? Do we need to worry less about the level of significance, and saving 1 or 2 lives or a smaller number of lives is really important because of the social determinants of health in our setting? I don't know. It's just something I think about, that maybe there should be different levels of significance. I don't know, sometimes.
Well, I am mindful that we are just past the hour. So I want to say thank you to all of you for joining us today and joining in this great discussion that we've had at the end. We look forward to, fingers crossed, seeing you in person in the new year, barring any respiratory illnesses or weather emergencies. I've heard the Farmer's Almanac says it's supposed to be a snowy winter. But glad we were able to have a nice discussion at the end here via Zoom.
Thank you.
Thanks, Catherine. Nice job.
Thank you. See y'all.
You the opportunity.
Very nice
Bye.
presentation. Bye-bye.